So today we're going to go over dental bonding continued, pick up where we left off from last week, and then a few other important tidbits. So some of you may or may not be aware that in Massachusetts, there is a referendum up for public vote coming this November. This is probably the most important public vote that we're going to see in our career. At least in my 15 years, I have never seen anything even remotely close to this. So what this is, the state of Massachusetts is attempting to allow the public to vote on the percentage of, let me see if I can get this right, how much money the insurance companies bring in per year. A certain percentage of it should be allocated to patient care. To state another way, this referendum is hopefully going to limit how much dental insurance companies that work in Massachusetts can take for profit. Right now, we have no idea. It's somewhat private. The insurance industry, at least on the dental side, has been pretty successful on preventing that kind of information and transparency. So I'm going to click on this link, and if you guys want, please let me know. But it's essentially vote yes on 2fordental.com. This is mostly run by the Massachusetts Dental Society, I believe, or at least some dentists that are involved with the Mass Dental Society. That's how I became aware of this. Long story short, this is what is going to be put up. I'm going to read some of this, and I don't like being verbose and verbatim for things in text, but I think this is worthy of that kind of focus and attention. So again, this is in Massachusetts, and why are we bringing it up here? So I guess before I get started, if this gets passed in Massachusetts, this is going to be a beacon and a lighthouse for the rest of the country to follow suit. Right now in medicine, there already is a requirement or a minimum threshold at which the insurance companies have to spend on patient care.
Medical loss ratio.
Medical loss ratio. Thank you, Dean. Well, Dean, tell you what. So Dean is from Mass. He went to Tufts. Do you want or BU or Tufts?
I'm sorry, can you repeat that last part?
Where did you go to school? Is it BU or Tufts?
And in Philadelphia.
You went to school in Philadelphia?
Yeah.
Oh, I guess because you knew so many of the faculty at Tufts, I just assumed you had gone there.
Oh, I taught part-time. That's how we got our accreditation for the PACE approval.
Okay. Well, I knew there was a connection there. So, Dean, you're somewhat familiar with this. Do you want to take a stab at it? Or you want me to kind of go down the list
here? Yeah, so I can continue. So the only reason I have my camera off is I got diagnosed with pneumonia, so I don't want you to see me coughing and blowing my nose and everything. But so this was actually started by a grassroots organization. Let me see if I can pull it up on my screen. So it was the Alliance of Independent Dentists, and they have their own separate website, fairdentalinsurance.org, and they're the first organization, grassroots. MBS deserves a lot of credit. They kind of jumped on board, but for better or for worse, there's actually two separate organizations voting for Yes on 2. And the MDS has that Vote Yes on 2 website. Just Nick did a great job explaining everything else so far. There's a medical loss ratio for medical insurances. And in Massachusetts, it's currently at 88%. So the ballot is not even asking for 88. It's only asking for 83%. Obviously, Delta Dental being one of the bigger ones doesn't want this to pass, so they've already spent at least $4 to $5 million. And we've seen some TV ads coming on board saying this will increase costs for patients, which I think someone did a study at Tufts Executive Center and said probably not much is going to happen. Yeah, but this is one website. Like I said, I can send Nick the other website so we can distribute it to everyone else.
Yeah, that'd be great.
Yeah.
Yeah.
And right now there's a big push just to get the patients or just regular Massachusetts citizens involved too, just because obviously all the dentists know about it, and we all know how beneficial it's going to be is for everyone. And just like Nick was saying, if it passes in Massachusetts, it's going to serve as a foundation, a springboard for other states to follow, whether it's just passed by your state officials or whether you have ballots put on your states. I'm part of the Massachusetts AGD. I had actually asked our president to see whether she would ask the other AGD chapter sites to contribute, and then if they did, we would return a favor in the future with funding of our own. I know the ADA spent $5 million. They had a $5 million donation for the MDS. The AGD national chapter obviously is much smaller. I think they gave 50,000, which is still a lot which is great. So we appreciate that. Yeah, but this is history in the making right now. Hopefully it's going to pass.
Yeah, I mean this is huge, and it kind of snuck up on us. As president of the Maine AGD, I haven't heard from the Massachusetts AGD chapter. I also didn't notice that they were at the bottom of the. There was a list of all of the different societies who have been who have donated or at least been involved. I mean, Louisiana Dental Association, Maine Dental Association, but I haven't seen too much else in the way of New England, which is pretty sad. With that said, I think this is pretty new news for everybody. I promise to do my part on spreading this as far as I can. Thank you, Dean. And for those of you who don't know Dean, Dean is the co-director of the New England Master Track with myself. Dean and I were in Track 10. Dean is also a master in the AGD and a very involved person, as you can tell. Dean, I'm sorry to hear you're under the weather, but happy to have you just the same. In a nutshell, when a company needs to have profits, otherwise there's no motivation for them to continue. Essentially, what's being asked right now is that 17% will go to profits, which is the opposite of 83%. So 83% will go towards the premiums needs to go to patient care. That's a pretty reasonable request on behalf of the public, asking the dental insurance companies to limit their profits to 17%. One question I've had, because I reached out to a lot of my mentors to get their takes on it, people that have been in the profession longer than myself. The first thing two people said, which I think is important, is what are the unintended consequences of this? And I think this particular sentence right here does a pretty good job of addressing it. Insurance companies who oppose this initiative are trying to scare voters by claiming that it will increase dental insurance premiums. Fortunately, the way this bill was written, Question 2 specifically prevents dental insurance premium increases above the consumer price index without approval by the state. What does this mean? Essentially, the CPI, or consumer price index, is basically what's the acceptable rate for a good. In this case, the good is a service, which is dental care. What does this mean? The state's going to be very much involved with making sure that this doesn't go out of control. What this is going to do, it's going to force the dental insurance companies to actually increase how much coverage they provide for patients. I think the unintended consequence is probably long-term in the fact that it's going to cost more for employers to get dental insurance, and it might actually decrease the available marketplace for employee-sponsored dental benefit plans. With that said, that's just an unintended consequence that we should probably pay attention to. I have not done my due diligence here. I just found out about this 2 days ago. With that said, I'm sure Dean has some insight on the potential unintended consequences.
I'm glad you brought that up. One last thing I forgot to mention: if they don't reach that 83% threshold, they're actually supposed to refund all remaining money back to patients. So whatever premiums they paid, they'll get back almost like a refund. So in effect, their premiums will essentially go down if that money's not spent.
So that kind of answers the question that, the unintended consequences are built into the legislative wording of this, which is great. But there's one thing here that's going to increase, and it's transparency. If there's anything the dental industry needs more of, at least from the perspective of the consumer and the dentist who's trying to deliver the care, it's more transparency. And I think through that, we're just going to get a better product. Anybody have any experience how this played out in medicine? I am unaware of when this happened and how it played out in medicine. That's kind of my next foray into this particular topic.
The only thing I can say about Massachusetts is that we already have a law in place, and that's where we had the 88% ratio as the baseline, and instead we're using 83% right now. So it seems to be working on Massachusetts. But I haven't done hard facts into the research on the history behind it, though.
Yeah, I'll keep people up to date as I dive into this. I do know every state has a provision for medical you can see I'm stumbling with the particular terms and phrases with this. There is a requirement for medical care in every state. In other words, there's a minimum threshold at which the profits have to go toward, or the revenue has to go towards actual patient care. So stay tuned. If you know anybody in Massachusetts for this, I can't imagine any dentist in Massachusetts is not aware of this. With that said, I'm always surprised at how some people just don't seem to get information. It really requires friends and colleagues to kind of spread the word. Call your family and friends. This is not just a dental topic. This really has to do with the public. Even if you're not a PPO dentist, this absolutely is going to affect the trajectory of the earning potential of your career. And then lastly, if you have time, drive down to Massachusetts and pose as a Massonian and vote yes on question 2. Whatever you can do would be super helpful. But as part of the main AGD, I've already sent an email out, or I've started crafting the email. I don't know if I hit send yet because I came up on this meeting. But the main AGD absolutely is going to try to contribute somehow, either monetarily or sweat equity wise. All right, on to some dentistry. Anybody have any thoughts or questions about this before I change over to clinical stuff? All right, so this photo was sent by our own Dr. Phillips. Unfortunately, he's currently probably 20,000 feet in the air coming back from Kansas City, so he's not able to make it. But this was a case he had done. This was a Maryland bridge that he was replacing. The Maryland bridge had been 35 years old. Unfortunately, wasn't functional anymore. But this was an Ovate Pontic created by the dentist who did the Maryland bridge many years ago. And you can see how nice the tissue was. And you see how nice the papilla is. If we have a nice papilla, guess what we have underneath it? We have good bone. So simply by doing an Ovate Pontic, and we went over this, I believe it was session 13. If this topic is not fresh in your mind, it's super relevant to the restorative dentist. Whenever you do FPDs of any kind, even if you're going to do implant site development, understanding how to do this is super critical. But I thought this was a super nice photo, not only because he used 2 cords and you can see how nice his retraction is, beautiful preps, but really the fact that this had been in place for 35 years and look how nice that tissue is. Now, if that tissue is there, the bone underneath it's there, which means this is probably a better site for implant placement. Can't say for sure. We haven't gone down the road of trying to treatment plan this for the patient. But I think the point holds that when you support the tissue, you support the bone. Obviously, if the bone had receded, this tissue wouldn't look like this. So if a conventional ridge lap Pontic had been done, you wouldn't have seen this. There's his temporary. There's the final temporary. He and I were talking about how to sculpt this tissue to allow for symmetry across the zeniths of the teeth. What would be the first question to ask when it comes to how to develop that site? For those who recently watched Dr. Hempton, this should be fresh in your mind.
Sorry, repeat that again, Doc. I got a little glitchy on my side.
Sure. So when looking at this photo, and we are trying to ask the question, can we create a situation that does not involve a modified ridge lap being purely a prosthetic kind of veneer over the tissue, which to me is not the answer. But if we want to make an ovate Pontic here so that the zenith of this tooth here is at the same level as the adjacent tooth, what is the question we want to ask? There's a couple different questions, but one in particular.
Where's the bone?
Attached tissue we have?
So where's the bone? Where's the attached tissue? What about the specific anatomical landmark? That might help us.
Talking about the freedom?
You're getting there.
No.
How about a hint? You can't see it here.
Oh, mucogingival junction?
Correct. So the mucogingival junction, whenever we start thinking perio, we just want to know where that is. which is one reason why I love having photographs of our cases. We are restorative dentists. We go in and we treatment plan restoratively, and we sometimes miss things like where's the mucogingival junction. So let's just say we didn't have this photo and we sent this to the lab and we said, oh man, I forgot to do a pre-prosthetic perio surgery to modify that site. So I'm just going to tell the lab to make an Ovate Pontic here. Well, where are they going to make it? And where's the mucogingival junction? So these are questions we should be thinking about kind of before we even start prepping teeth. Where is the mucogingival junction is very important because it tells you what kind of periotherapy may or may not be advisable here. Here's an example. This patient has what looks like medium to thick gingival biotype, which means we can very confidently remove this tissue as long as we're not getting into the zone close to the mucogingival junction. Let's assume it's up here, so we're probably far away. We could safely reduce that tissue with either electrosurgery, a laser, a fine diamond burr, a scalpel, if somebody chose a scalpel. The point is that we could predictably do that. But there are times, especially when the site doesn't have an ovate pontic or any sort of pontic that is holding the tissue up, that the mucogingival junction actually makes its way closer to this area here. So answering that question is important. Having a photograph is important. Understanding the biotype so that you can understand what will happen if any sort of periodontal therapy is done, what will happen after that fact. So the first question is always, where is that mucogingival junction? Because it looks like it's far away, and he has some more photographs coming as soon as he brings the patient back. Again, this was kind of an emergency appointment, so he wasn't necessarily trying to dive into long-term plans. I don't even know if the patient's decided whether or not he's going to do an implant or not. Moral of the story, he wanted an upgraded aesthetic and also just get rid of that Maryland bridge, which was giving him problems. So now that we know a little bit more through the photo where the mucogingival junction is, I would safely say we could use something like an electrosurge or a laser or a fine round diamond burr or football burr to reduce that tissue away to create that sculpting. That makes sense so far?
Yep.
Why would laser be advantageous over electrosurge here?
Tissue dieback.
Correct. Why does tissue dieback happen more with an electrosurge?
Because you kill the vessels and you can lose up to like 3 millimeters beyond the area that you cut. So that could be pretty serious, especially in this area.
Yeah.
The aesthetic.
Yeah, you really have no control over how deep the heat penetrates. With an electrosurge, you're using you're using all heat to actually reduce the tissue, whereas laser, you're using some heat if you activated the tip, and then actual energy interaction with the pigment in the tissue to cause some heat, but you're also causing some vaporization or some heating of the water within the tissues to cause vaporization of the tissue. So there's a lot more effect going on with a laser compared to an electrosurge. With that said, electrosurges are great, but this is a lot of tissue to reduce back, and if you're not careful, I do think an electrosurge might be a little more aggressive. So choosing the right weapon for this might be something to consider. With that said, I've used round diamond burrs for stuff like this with a lot of success. So what I would do is not take your final impression until the tissue's done healing. I would reduce back with a diamond burr till about 1.5 to 1 millimeter short of where I want it to be. And then I would create an ovate pontic that supported that tissue. In other words, I'm giving myself a little bit of a buffer. A millimeter I can correct with adding material down the road to the underside of the ovate pontic. In other words, tissue sculpting using biomaterials. Let me rephrase that. I get the 90% of the reduction with either a laser or a round diamond burr. I leave a millimeter in case there's any dieback. If there is, I'm okay because I'm still short of the anticipated zenith. But that millimeter I can compress with flowable composite underneath the ovate pontic after that's done healing. And I would use that last millimeter, or I would compress that last millimeter using the technique of tissue sculpting or tissue contouring like we do with implants. Then you're ready to go. So that would be the ideal way to gain control of maximum aesthetics here. The flip side of it is you could just have the lab actually have the zenith emerge from the tissue at the same dimension as the contralateral tooth. My experience tells me that lab technicians look at the incisogyngival dimension and not the buccolingual dimension of that where it emerges. Does that make sense? So 90 degrees from the plane of this particular picture, I want to have the final crown emerge from the tissue at the same buccolingual dimension as this tooth here. My experience tells me lab technicians do not understand that, so I very much articulate that to them as best I can.
So you're saying you'd get back like basically a facial fin if you don't ask for it correctly?
Sometimes, yeah. I mean, you get whatever they think is right.
Can you say what you can ask for again? I didn't catch that completely.
I don't have the image here, but let's, in our mind's eye, rotate 90 degrees so that we're looking almost from the side of the patient. I want to see the tooth emerge, the pontic emerge from the tissue at the same buccolingual dimension as this tooth here. Just sleep on it. It's an important fact that if we do not relate to the lab, it might look like it's emerging from here, but they only made it look that way from this angle.
Right.
Then you turn it from the side and it doesn't look the same. The optics do not look the same. The light reflection is not the same. You really want to have it emerge from the tissue just like you would if you put an implant in here and you wanted it to match the emergence of this guy. It's just a little different. It's an ovate pontic, so you have to communicate that to the lab.
I'll routinely see that too. Like it's short horizontally in the buccal area.
Yeah. I think the horizontal word, I think, is maybe the missing key. Thank you, Mark, for bringing that word in. Just sleep on it, everybody. I promise there's something here that's worthy of consideration. With that said, if you sculpt the tissue ahead of time and you tell them to have it emerge from the pontic exactly the way the tissue is, then you don't have to worry about it. It really depends on, are you having them fabricate the final appliance before the tissue is done being sculpted or after? Ideally after. That just takes more work on the front end, but also with increased predictability. So great job, Dr. Phillips. Hope you get to watch this. Any thoughts or questions about the ovate pontic? We went over this on session 13, I believe. I think it's an important skill to have. All right. Dr. Regan, without giving her full name, that patient ring a bell?
Beautiful. Yes. Just saw them today.
Excellent. Well done. Didn't even give the gender. That's great. All right. So this patient showed up, I believe, in Dr. Regan's chair maybe a year ago. I guess the history of the patient's not that important. Long story short, this patient needed an upper denture. The typical workflow, as somebody who's gone to dental labs and seen what is sent in, I've done this countless times as a way to get better myself. It's easy playing Monday morning quarterback when you do that. I promise I've been the person that has done what I'm telling you not to do, which is to send a case like this to the lab saying, please fabricate an immediate denture. Anybody want to take a stab at why that would be inadvisable? Even if you mean
like I do. That's not a good thing.
Go ahead, Zach.
Well, you mean every case I've ever done? Fabricate immediate denture here. Go.
Yeah. I mean, in dental school, we might get 1 or 2 dental experiences with dentures, and how many of them are immediates?
I mean, that's a nice stable occlusion to fabricate a good VDO from. Look at that. She's got tripod support on her 3 teeth. Perfect.
Let's say you're correct and the VDO and the occlusion is where it needs to be. What's the thing here that is glaring at us?
Great if you want them to look like Mr. Ed.
Got that horse teeth. So the real problem, and thank goodness we took a photo. I mean, you can see how much bone reduction we're going to require to give this woman a normal smile line.
Yes. So bone reduction is the answer. The diagnostic process is that she has a hypertrophic anterior maxilla. And what the hell do we do? I mean, do you tell the lab? Even if you wrote that on your lab slip, the lab technician wouldn't know what to do. We have tools that we never had before. I'm going to share the analog method that I used before current methods like Chrome, surgically assisted bone reduction guides. There's all kinds of fancy software out there that allows us to do some really, really absolutely crazy things. But it all comes with a price. This patient didn't have the money to do, three-dimensional CAT scan guided surgery. So I just want to walk everybody through what I did. Obviously, this patient needs some sort of bone reduction. You look from the side. If we just take the teeth out and a denture is made, I think Libby said it best. I mean, she's going to look like Mr. Ed. It's just not going to look good at all because of all of the bone that's supporting the lip already. You add an acrylic flange in there and you're going to have an aesthetic nightmare. What does this image tell us?
So this is her repose. Yeah?
Yeah, so with an immediate denture, what do we not have the ability to do?
Aesthetic try-in.
Aesthetic try-in, putting a wax rim in, all of those steps. We cannot assess the aesthetics ahead of time. What we have here are her natural teeth. This is her wax rim. So when you do an immediate denture, first and foremost, use the natural teeth and somewhere on the teeth to determine where your final incisal edge is going to be. In other words, you're using this as your wax rim to communicate to the lab where the incisal edge of the next teeth are going to go. If you just tell them to make you an immediate denture, again, I've seen it in the labs. That's literally the prescription. Fabricate immediate upper denture with just a set of models. No face bow, no wax rim, no models with an occlusal plane of any kind. We have to communicate. We have to tell the lab something. Otherwise, we're going to get back something that we don't like. And then we just say the lab is a crappy lab or they didn't do a good job. They can only do as good as the information that we provide. So this lip at rest photo is always the beginning photo for aesthetic workups, whether it's with a wax rim or you're doing a composite mock-up for a composite delivery of direct resin veneers. The point is, every case really starts here at repose. So she came in kind of an emergency. I don't know if Regan, you or I took out this guy here, but this guy came out shortly after this photo. And then I was left with, so by the way, both Dr. Regan and I worked on this case, so you'll see me kind of bouncing back and forth. We were trying to get this lady something quickly, and it required both of our schedules to do so because she needed sedation and she was medically compromised. So that guy came out, and then at that point, I was like, well, give me a wax rim. That's what I got from the lab, but it actually had wax on it. By the time I was done getting the wax rim somewhere close to where I thought she should be, there was no wax left, which isn't surprising. She has this huge maxilla. So her wax rim came over this guy here, and there was no wax left. So I was like, okay, the wax rim is of no use to me. What do we do? Let's go to her CAT scan. So I wanted to get a sense, and not everybody necessarily has access to a CAT scan, but I wanted to get a sense, how much bone does she have? So looking from the side here, this is her side image. And it might be hard to appreciate, but look how scooped that is. For those of us that place implants and we look at CAT scans all the time, this is really pronounced. Normally it comes down in maybe something like this. Don't worry about the position of this implant, that's irrelevant here. I was working on something else when I put that implant in. But essentially this was too much bone. But how much? You know, it really depends upon where the lip is in relation to where the future tooth is going to go. So what I did, I inserted a tooth using the CAT scan software. So I put a tooth here and I was like, well, where does that tooth go in relation to her lip? So I used the image, the photo that we had from before. This guy right here. And I said, with a lip at rest, she's showing too much tooth there. For a lady of her age, we'd like 1 millimeter, maybe 1.5 millimeters. That's probably 3. So just splitting the difference there, I'm going to say maybe 2 millimeters short of her current incisal edge. So then I came over to the CAT scan and I put this tooth somewhere in that vicinity. I'm just trying to get an idea of how much bone she needs to reduce. We could play with this for days, but I just want to then pan over to the side image here. Now here's the tooth that I put over here from the side, and you can see how much bone would be in the way of us putting a natural denture tooth there so that her lip rests appropriately. Is this confusing or are people following me? This is, again, lots of thought went into this as I was doing it. What I was trying to do was gain some sense on how much bone reduction needed to happen. So then I came over to the model and I reduced however much bone I went to the lab, and this was me reducing it, so that I have some idea on surgery day how much bone to reduce. Now, Dr. Regan was the one that did the surgery, and he did a heck of a job, and I can't wait to share the CAT scan that he had. But ultimately, we ended up creating a surgical stent. Now, you can have the lab make you a surgical stent, but where they reduce the bone on the model is really up to the skill of the technician on the little bit of information that they have. Moral of the story, I did this myself based on information that I had as the clinician, and I reduced it until I was happy knowing that the amount of space I've reduced is going to allow for better prosthetics. And then I had the lab make a surgical guide. Now what this is, it's essentially a tool that is used after Dr. Regan laid his full flap, because again he was placing implants in here. He did the alveoplasty, and he kept reducing until he could put the stent on without tissue blanching. Again, he made an incision all the way around. Each time he put the stent back on, he would put the tissue back, in essence passively reapproximating the tissue. And then he would place this in and put his thumb right in the center, and wherever there was blanching, he knew he had more bone to reduce. Once he reduced enough bone, he would not see any blanching except for where he was pressing his thumb on. Dr. Regan, you want to share how that experience went for you?
Yeah, I mean, it was a lot of in and outs. I mean, it was a trial. It was a trial and error kind of thing, because you'd start reducing from one area and then you would place it in and see that you're now rocking. But yeah, just back and forth, we got it.
Yeah. You know, the other way to do this is to actually have a bone mounted guide, which we do with Chrome all the time. But Chrome is, I don't know, what's our fee from Roe Dental Lab? $7,000?
You really want me to do that? It's like 13.
Well, it's a lot of money that this lady didn't have. So this was the best we could do to try to get a predictable outcome. We don't have any photos of the denture being delivered. How did it look? I actually haven't even talked to you about this yet.
Oh no, I saw her today. She's great. It's spot on. She looks completely normal with her denture now.
Awesome.
Yes, we got the bone where we needed it to be.
Yeah, that would have been really anticlimactic if you had said it was crappy. But, you know, it's not an exact science. But what we do know is we used her initial image and we used a CAT scan to create a pre-prosthetic stent that allowed us to try to get something much closer to ideal. You know, I guess we got it close enough that it looks good. Yeah. Let's hop on over to the CAT scan, which is beautifully done, Dr. Regan. So there are 6 implants, all very nicely placed. She's doing locators, I believe.
She's going to do a maxillary overdenture. Yep.
Yep. Beautiful. You can see this guy here. Looks like you did some densiburs, I would imagine.
Oh yeah, we dented universally.
Awesome.
You know, if this was an all-on-4, we could have loaded it. She actually had primary stability across the board, like the 40s and 50s.
That's great. Very well done. This was a last-minute switcheroo. Dr. Regan stepped up to the plate. He's a pinch hitter, batting .350. Well done.
Is that good?
You really don't watch sports, do you? All right. This was also something I used for the lab, a stick bite. Very, very helpful tool to communicate the horizontal plane for the patients. Yes, a face bow is absolutely the best tool. Again, this patient was, for lack of a better term, rushing to get this done. We just didn't have time to do all of the normal steps, so we just used the most analog versions here. The point being, many general dentists don't know how to use a face bow. Although I advocate for a face bow, this is a good tool to have in the toolbox when you don't have a face bow. The stick.
Do you take a photo of that in the patient's mouth also then?
I do, yeah. So what Mark is saying, if you take a photo of it, you want to explain what's important about that, Mark? You want me to go about it?
You can. You got this.
Yeah. So if you take a photo with this in the patient's mouth, you want to make sure you get the eyes in the photo. And what that does for the lab, it helps them see where that stick is in relation to their horizontal plane in between their pupils. I would love to say that every time I've done this, I get the material to set perfectly so that that stick is perfectly horizontal. In reality, that's not always the case. So if you take a full front-on photo, the lab can adjust for any cant that might exist with the stick. And the stick is normally a little bit longer than this. I don't know why I shortened it this much. I think I might have shortened it after it came back from the lab. Not sure. But the point is, the stick bite allows you to communicate to the lab where the horizontal plane of occlusion is going to be. Always remember, lab technicians don't have soft tissue landmarks. And if we don't communicate to the lab where we want things to go based upon the extraoral structures, we're going to get back what we get back. So, any more thoughts or questions about the stick bite? I just threw it in here because it was in her case. Obviously, I had to send them something because her teeth were not obviously parallel, and it sounds like we got it on. All right, here's an image that was shared recently. The question was, do I put a post or not? Let's not go down the rabbit hole of post or not post. But always, when you reduce all of the internal decay, such as a tooth like this, just picture in your mind's eye what is going to be left after you prep the tooth for the crown. And then ask the question, do you need a post or not a post? Super obvious, but I've been around maybe 5 or 6 teeth like this that within a year or two, they come back and the whole tooth is broken. You know, literally it's just sheared off at the gum line. Half of those were probably teeth that I did. So I just wanted to show this photo because I think it's very important to always ask yourself that question, what do I do here? Now, we might go down the road of we need a ferrule and we need a post that's bonded, so on and so forth. Just be careful when you see teeth like this. Anybody want to comment here? Somebody was going to chime in.
No, I just want to see those gold foils on the next slide. That was great.
All right.
Nice.
What is I would love to do a gold foil.
Oh my God, me too. It's hard.
What is this arrow pointing at? Not the furcation, but there's something else in this image that's super insightful. And this came off Strupp and Brum's website. And if anybody follows them, they definitely know the answer to this.
You're pointing to like keratinized tissue?
Sure. How about this?
You premolarize the tooth?
Yeah, I've never heard that term, but I like it. Premolarize. Barreling is the term I think they use. The reason why this image is super helpful is because we have a lot of contrast between this furcation, this prosthetic furcation, and the prosthetic furcation on the tooth next door. So if we look at this barreling, what Mark said is premolarize, essentially creating two lobes that are almost like premolars, and then you have a sluiceway in the center. And when we have very periodontally compromised molars, it's very important that as we're prepping, if the root surface has a concavity right here, that we carry that prep all the way up. Many of us already know that. But how many of us tell the lab to follow it? Labs don't do it. What happens is you have this little chamber or roofing. It's a little bit upside down, so on a lower molar it's called a roof. Here maybe just a floor. The point is, this is not self-cleansable. There is no sluiceway here. So this crown was not designed with periodontal health in mind. So a lot of what this particular clinician and his partner talk about is making sure the lab technicians create this barreling effect. For those in the practice, I have a letter somewhere in the shared drive. I think I forget what it's called. Just remind me and I'll print it out. That talks, I have a couple photos that I drew out and then photocopied that help the lab technician understand what we're saying here. I haven't found many labs understand what I'm saying when I say barreling. Premolarizing may be a term that they're familiar with, but this isn't common anymore. This was very, very common back in the day of what was called perio-pros combination therapy. There was a very strong connection between the periodontal apparatus around the tooth and the prosthetics or the restoratives that went on the tooth. That's been lost. I mean, that was very strong back in the 70s when we didn't have implants and we didn't have lasers and all the crazy things we have today. So a lot of focus and attention was put on these finer details. Those fine details still matter today. I just don't think they're emphasized as much in the dental school curriculum as much as they should. Thoughts?
We still learned it when I graduated. I can't say it was a huge mainstay, but at least one or two perio faculty made sure to really hammer that one home.
Yeah. Yeah, and it's the perio faculty that are teaching this, in great part because they're the ones that see the periodontal breakdown when it's not done. What's important is not every patient's going to have perio breakdown as a result of it, but many will. So that's definitely an important distinction there. Well, we were going to go back to dental bonding, but we're up at 7:50. Let's go over to it. We have 10 minutes. All right, so last time we talked about the concept of dental bonding. Important to understand that one side of the dental bonding agent is hydrophilic and the other side is hydrophobic. Understanding this allows us to make sure that we follow the directions appropriately. We talked about the Velcro concept and the fact that covalent bonding up until recently was not part of dental bonding. Luckily, we have universal adhesives, here we go, which were introduced around 2011 that added MDP, which is known to have covalent bonds not only to dentin, but also zirconia metals, so on and so forth. It's a very chemically active compound. And then we went over understanding what the different systems are and how they land in the different generations. Again, the 4th generation is a 3-step process where you etch the tooth with phosphoric acid, you prime, and there's no curing after the primer. Essentially, the primer is the hydrophilic component, and then the adhesive is the hydrophobic component. The 5th generation, they combine the two. And in general, when you combine steps, there's a high likelihood you're going to decrease clinical effectiveness to a degree. Then came along the 6th generation, where the acid, essentially the primer has an active acidic component to it. So the primer was actually doing the etching itself. You would scrub for 20, 30 seconds, air dry, and then add on your adhesive. And then finally the 7th generation, which we made the very strong point, are too leaky and too hydrophilic to have any sort of clinical relevance in today's day and age. But there was a good 7-8 year window where everybody was switching to self-etching adhesives, or at least the self-etching 1-bottle adhesives. Luckily came the universal adhesives, and we now have things like Scotch Bond Universal, All Bond Universal from Bisco. These are very, very good products that have stood the test of time. With that said, it's only been 10 years, 11 years. With that said, we've been using Bisco's All Bond and Scotch Bond Universal for 6 years now with a high degree of success. We talked, and this is important to kind of reiterate this stuff, that's why I'm going back over it. If you're ever looking at bond strength tests, it's good to know what the different bond strength tests are actually measuring, whether it's tensile forces, compressive forces. There's all kinds of different tests, and sometimes the companies will make the data fit their narrative. In general, when you have Dentin bond strengths due to microtensile forces, you want to see something north of 20. A lot of these universal adhesives are somewhere just about 30. Here is a description of the different tests that are used to measure the strengths. But what's really important is all of these tests are done under initial conditions. And we talked a lot about last time about the fact that over time there's degradation of the adhesive layer through hydrolysis of the collagen in this layer here due to MMPs. Unfortunately, it's just not a long-term bond. We know composite leaks on dentin over time, which is why enamel is our preferred substrate when it comes to dental adhesives. So coming back over here, when it comes to bond strength tests, what the companies advertise is not really that important. What I like, and this comes from the literature, I wouldn't say that I came up with this, but what I think is important based on the literature, age bond tests instead of initial bond tests provide much more data as it incorporates bond breakdown over time. What actually causes failure of a composite restoration, it's not usually bond failure, it's secondary caries due to breakdown of the bond layer. Therefore, short-term bond tests are insufficient. Does that make sense?
Yep.
So this is why understanding what's in your bonding agent and understanding how to use those tools is so damn important if we want long-term predictability of our direct restorations and indirect restorations if we decide to use bonding. Anybody want to share about the challenge we had last time about looking at the directions of their bonding agents? Humility is encouraged.
Can I ask a question?
Yeah.
About, okay, so you had mentioned doing chlorhexidine because something about any MMP, I can't remember exactly what it was, but can you go over that point one more time?
Sure can. Let's see.
I just want to make sure I'm doing things in the right order.
Yeah, so there is a lot of conversation out there about, do you do chlorhexidine before etching or after? I know some schools teach it before. Frankly, I don't understand why. The rationale is that you're killing the bugs in the smear layer, but the smear layer is removed from etching. So I guess it applies if you're using a self-etching adhesive to use chlorhexidine first. I use chlorhexidine after I etch because I use a phosphoric acid etch. I think that's superior to using self-etching adhesives. Because of that, I want to make sure I remove the smear layer and then I add the chlorhexidine on there. So here's kind of the 10,000 foot view on what chlorhexidine does. So the hybrid layer formation involves collagen, and MMPs, which are enzymes located in our own plasma, over time degrade the exposed collagen, and then you eventually have a breakdown of the hybrid layer. So chlorhexidine deactivates the activation properties, but this is yet to be proven directly in the bond. Basically what they were getting at here, directly improve the bond. There's been some studies to say that this effect degrades after about a year to a year and a half, and the long-term bond isn't necessarily affected by it. So that's important to know. With that said, I feel better knowing that I'm re-wetting the collagen and I'm disinfecting it, but I'm also giving us an 18-month period of time where we're having less breakdown of the collagen based on the MMP activation. So to answer your question, it's after the etch step. And they went over this here. There's all kinds of studies. If you guys want this, happy to share it with you. Take home message.
Thank you.
Yeah, chlorhexidine pretreatment may not be as important as we once thought, but stay tuned. Then we go over glutaraldehyde and HEMA. This is Gluma. Glutaraldehyde also inhibits MMPs. Glutaraldehyde is antibacterial, so on and so forth. The only reason I don't really care for this has to do with HEMA. HEMA is a hydrophilic monomer that has been shown to improve initial bond strengths, but over time can actually decrease longevity of the bond. So that's why I don't necessarily use Gluma that often. I rely on chlorhexidine. With that said, I don't think you're wrong if you use Gluma. At the end of the day, Gordon Christensen said so it must be correct. But there's a lot of literature saying this isn't necessarily the way to go. Using HEMA as your hydrophilic monomer might be a thing of the past. So we could go on and on and on about bonding here. Let me go back and just go over this. How to optimally dry something. ADEC air dryer, that was very popular in the 90s and 2000s. For a multitude of reasons, that's kind of lost favor. What I have found very helpful is just using the high volume evacuation suction. So you just have the assistant or yourself put that right over the top. It seems to be what's left is an optimal wetness. So how to optimally dry, the inverse of that is having properly wetted collagen. Cotton pellet is another method. I actually learned this from a Honduran dentist when I was down in Honduras. They don't have fancy equipment, so she was using a cotton pellet to remove the water and make sure she had enough of a wet surface. On that note, look forward to seeing everybody this week. And don't forget to reach out to your family and friends in Massachusetts.
Sounds great. Thanks, Doc.
All right. Good night, everybody.
Thank you.
Thanks. We'll see you later.
Later.